Okay, I feel like now is a good time to start. Good morning, everyone. Welcome to Community Cares and Project Echo, the Back to Basics series. Today's session is on lung cancer and tobacco cessation. So this is just a quick disclaimer that the information contained in this presentation is not substitute for medical consultation, and the physician should always be consulted for any health problem or medical condition. This is today's agenda. We're going to do a Project Echo series overview, introductions, the didactic presentation, a case study, and then we'll do questions and answers at the end. So a little bit about Project Echo. Project Echo is a movement to demonopolize knowledge and amplify local capacity to provide best practice care for underserved people all over the world. The Echo model is committed to addressing the needs of the most vulnerable populations by equipping communities with the right knowledge at the right place at the right time. So for more information on Project Echo, you can visit echo.unm.edu. So we're going to start with our didactic speaker, which is Monica J. Gills. Monica is a seasoned registered respiratory therapist with over 25 years of experience across neonatal to geriatric care. She earned her MAS in 2006 and became a tobacco treatment specialist in 2013 through Rutgers University. Monica launched the first outpatient tobacco cessation program at her former organization and has since educated both the public and health professionals on lung cancer prevention and tobacco cessation. Her career includes extensive work with veterans, lung transplant recipients, and community outreach through Rutgers Cancer Institute. Monica is deeply committed to helping individuals live healthier lives through education, support, and compassion. Her mission is to educate and empower others, especially young people, to make healthy choices for life. And then we have our case study speaker, Carol Frankie Spears, a tobacco treatment specialist at RWJ Barnabas Institute for Prevention and Recovery. And she's actually here right now, so I'll let her introduce herself.
Hi, yes, my name is Frankie Spear. As they said, I am a tobacco treatment specialist. I currently work at RWJ, and I have a background as a special ed teacher. I've also worked as a certified brain injury specialist, and I've worked with addicted populations as well. So that kind of gives me a bit of a gestalt-like approach with folks. I kind of borrow a little bit from each piece, and when I'm not doing this, I'm a creative. And that also comes into my treatment with patients as well. So that's a little bit about me.
Thank you. And I believe I'll pass it to Monica now.
Thank you, Sarah. Thank you for that nice introduction, and good morning, everyone. And yes, we are going to talk about Lung Cancer Awareness Month, which is in November. So we will be able to make sure our communities, clients, and patients get the information they need. The agenda for today will speak about strategies for prevention of lung cancer, some treatment options. We'll talk about the criteria for the LDCT. I'll use a lot of acronyms, so lung cancer screening with low-dose computed tomography. We'll talk a little bit about combustible and some smokeless tobacco, some health risks associated with tobacco use, why it's difficult to quit, services for New Jersey and the country, and question and answer session. We will see these commonly used acronyms in lung cancer care. So we know there are certain agencies that we go to for information, like the USPSTF, United States Preventative Service Task Force, American Cancer Society, the CTs, which we'll talk about, which is computed tomography, the low dose, and the two major lung cancers. We have the non-small cell and the small cell. For today's poll questions, we have 4 questions, and the answer will either be true or false. So if you could just take a look, these questions will be answered throughout the presentation. First one, you don't have to smoke to get lung cancer. Lung cancer is one of the deadliest cancers. Air pollution is a non-modifiable risk factor, and initial stages of lung cancer are usually asymptomatic. So please take your time, answer these questions, and we will also have a post test at the end.
We'll just give it another minute, see if we can get a few more people to answer. I think that's all we're going to get, so we'll continue.
If you look at this slide here, we know that the American Cancer Society, the CDC, and the National Cancer Institute has confirmed that tobacco is linked to these 12 different cancers. If you look closely, there will be some common cancers that may not even be here because there may not be a direct link with tobacco. But if you have cancer and you get those and you're smoking, that will change the dynamics of the cancer progression. The impact of lung cancer, we know it is the leading cause of death in the United States. When we look at lung cancer and you combine breast cancer, colon cancer, prostate cancers, all together, still more people will die from lung cancer than all of these together. Early detection is what we know will improve the outcome, the prognosis, and survival rates. We know that smoking contains 70 carcinogens that have been identified. So for the basics of lung cancer, when I mentioned in the previous slide that we know that lung cancer is the leading cause of death in the United States, it's actually the leading cause of death globally. When we talk about lung cancer, we have to understand the basics of the lung cancer. We know that the ACS has estimated for the year 2025, 226,000 individuals will get lung cancer. When we talk about the most basic form, we know that cancer may start in the windpipe, which is also your main airways of the lung. And that can be where an uncontrolled growth of abnormal cells develop. There are two types that we're going to speak about, and I mentioned it in the agenda, that there's small cell, non-small cell. And these are the two major categories that lung cancer has been divided in. So for small cell, SCLC, 10 to 15% of the population will get this type of lung cancer, making it less common. The only thing about this, it is fast growing. It forms in the tissues of the lung and spreads to other organs very quickly. Surgery is not always an option. And with small cell lung cancer, it's more systemic and rarely limited to just the lung, and often treated with chemotherapy because, again, surgery may not always be an option. When you catch small cell lung cancer in the early stage, there's usually about a 20 to 25% survival rate. But if it's caught in the late stage, survival rate can be as low as 3%. Now, when it comes to non-small cell, 80 to 85 of individuals that get lung cancer will have this non-small cell, making it the more common. It grows slower, and there are two types that are divided as to what non-small cell lung cancer is. And there's an adenoma carcinoma, which is the most common, and that's glandular in nature and that lines the airways. When it is caught early, it can be treated with surgery. And the other type is squamous cell lung cancer. It develops in the central part of the lungs near the airways. More advanced stages usually require a combination of chemotherapy, immunotherapy, and radiation. And as a tobacco treatment specialist, what we also want to add within that treatment plan is tobacco cessation. When I mentioned where some of the cancers may develop, depending on what type of the lung cancer, there may be where it starts in the airway. So we look at staging, we have from 0 to 4. When it starts in the airway before it hits the tissue, and that is something that can be treated a lot easier. Stage 2 is broken down into two other areas. This is when it starts to spread to the lymph nodes, and that tumor may vary in size. So we have to just be aware that when it comes to staging, it literally is referring to what size it is and where it has spread as the main tumor. Excuse me, with stage 4, that's when it has already metastasized, and surgery may not be an option at all. And this is where the chemotherapy and the immunotherapy and radiation therapy combined may help. So just know that once you are diagnosed and they understand what type of lung cancer you've been diagnosed with, they look at what stage you are at to see what your treatment options are. Some of the signs and symptoms, unfortunately, can mimic other lung diseases, making it a lot more difficult for individuals to get screened when they do not suspect lung cancer. So if you ever heard of chronic obstructive pulmonary disease, which is COPD, or you had heard of emphysema or someone who gets chronic bronchitis, they will have some of these same symptoms. They do have shortness of breath, they're coughing quite a bit. They may have a lump in their neck, which may be a swollen lymph node, and there is sometimes bleeding in the sputum when they cough up. And that even can be, if they have a lung cancer they're not aware of, the tumor sometimes breaks off as they're coughing, making it more blood-tinged secretions. And weight loss is very common with individuals with lung disease because you're breathing so fast and you're burning calories that you absolutely need to hold on to. So people with lung disease will not always think of cancer because these symptoms are so common. For 2025, when we look at the statistics from the American Cancer Society, we look at all new cancers in the year 2025. The data has been collected. One thing about data collection and surveillance, we have agencies that collects information, and that may be anywhere from 1 year to 4 years to get all these numbers. And I'll go back to that later on in our discussion so we could see why relevance of surveillance. So for males, we do know that the number one new cases of cancer are prostate, and for females, their new cases for 2025 are breast cancer, making it 32% of women will be diagnosed with breast cancer, and 30% of men will be diagnosed with prostate cancer. Now, when we look at the cancer deaths, as you can see for 2025, it is already determined that both male and female will succumb to lung cancer. In previous slide, when I mentioned to you breast cancer, colon cancer, prostate cancer, if you combine all those cancers together, there are still more individuals that die from lung cancer, and that's both in the female population and the male population. We'll discuss some of the risk factors. We know that smokers are 15 to 30 times more likely to develop lung cancer compared to people who have never smoked. Unfortunately, the tobacco companies have been very savvy at changing cigarette designs. They have changed filters. Even in the smokeless tobacco, they have different iterations on the market, which allows individuals to inhale much deeper, getting more of the chemicals that they get from tobacco. And we know factually that 80 to 90% of all lung cancers are directly caused by individuals using tobacco products. You can quit at any age. You're never too young, you're never too old to quit smoking. But if you look at this lifetime risk of dying from cancer, you see that there is a 17% chance of dying from lung cancer if you continue to smoke for the entirety of one's life. If a person stops smoking at age 50, there is a possible two-third reduction of dying from lung cancer. Early prevention is key. So if you look at this graph and you see when individuals continue to smoke, you're just risking the mortality of using tobacco. As many individuals may not be aware of, October, we are discussing breast cancer. There's great campaigns out there. Awareness is wonderful. We know in New Jersey, one of the towns, their police department has dedicated maybe I believe 6 trooper cars or police cars that are all pink for the month of October. The NFL sometimes will play with pink jerseys, pink socks, just to remind everyone how important it is to get screened. More women die from lung cancer than they do breast cancer. What my greatest wish and desire is that we would have the same campaign for lung cancer as we do for breast cancer, that when November comes around, the whole entire world, the whole entire country understands that this is Breast Cancer Awareness Month, like in October. I would love the same thing for lung cancer. Research has shown that since 1964, they have statistics that show 2.5 million individuals who have not smoked have died from health-related problems caused by secondhand smoke. We lose 7,300 people every single year that die from lung cancer that have never smoked. Unfortunately, we know that women, as I mentioned before, die more of lung cancer than they do breast cancer. Women are 25% more likely to develop lung cancer more than men would, and it has something to do maybe with the lung physiology and hormonal interactions. And I bring this up again about women at this slide because we have many women that were exposed to secondhand smoke from their significant others and their spouses. And a lot of them do succumb to lung cancer, unfortunately. And it's not just lung cancer. Here we also see heart disease. So secondhand smoke really kills at least 41,000 people every single year. I work for the Rutgers Cancer Institute as a clinician, as a tobacco treatment specialist. All my patients that I am treating, that I see, have been diagnosed with cancer, and they're also smokers. So I am contacted as part of the interdisciplinary team to now make sure that their treatment options and their treatments that they are being prepared for, perhaps being prepared for surgery, that we eliminate tobacco use as they're going for their cancer treatments. I encourage everyone that has been diagnosed to understand that there's life ahead. Not only are going to be survivors, but they will also thrive. So we tell them, if you continue to smoke after a cancer diagnosis, you're increasing your risk from dying from cancer. Even if we treat the cancer successfully, you're at risk for getting another type of cancer, a new primary cancer. And you risk that cancer you've been treated for to come back. And also there are some complications with cancer treatments. Some people have some toxicity issues. They feel horrible from the chemo or the radiation. But if you have those tobacco chemicals in conjunction with that, your recovery time is even delayed. And of course, the cost of healthcare, more prolonged treatments. In addition to being aware that people are using tobacco, so it's really the dangers of smoking anything. As a registered respiratory therapist, I have seen firsthand what tobacco can do to one's health, and it's the most preventable form of disease and mortality. So, dangers of smoking anything. Our lungs are only supposed to inhale fresh air. I bring this up because we know that there's evidence and proof that traditional tobacco does have 70 carcinogens, and those 70 carcinogens, I'll break it down how they came up with that number. There are 699 ingredients that make up 7,000 chemicals in combustible tobacco. Out of those 7,000 chemicals, 70 have been tested and are known carcinogens. There's arsenic, there's benzene, there's formaldehyde, there's cadmium, there's so many of these chemicals that we know are carcinogens. So when it comes to smokeless tobacco, the research is still out. I would not be able to say to someone with all honesty that yes, if you vape, if you use smokeless tobacco, if you use ends, that you will get cancer. There's no way for me to tell you that definitively, but as the research has shown, the FDA has this, that we know that more than 30 chemicals in smokeless tobacco are linked to cancer. When we think of nitrates, when they get broken down, you heard of nitrates in processed foods also. Nitrosamine has also been shown to change the molecular makeup of your DNA, causing these cancers. When it comes to only inhaling air, and I had mentioned smoking of any type is not good for your lungs, we do have proof that 1 in 5 deaths are caused from tobacco use, but also we have marijuana. We have dispensaries popping up all over the country, all over our states, and they're very, very popular. When we think of combustible tobacco or combustible products that people are smoking, marijuana is also combustible. And we know that if it's smoked, it leads to 4 times the amount of tar buildup in your lungs than cigarettes do. I will say that one more time. When you smoke marijuana and it's combustible, it's a combustible product, there's 4 times the amount of tar that gets deposited into your lungs. And this is a visual to show you the tar accumulation. So if you look at tobacco accumulation, that's how much tar gets deposited, and marijuana deposits 4 times the amount of tar in the lungs than tobacco. And again, I cannot link marijuana use to cancer, but we can link it to some lung injuries because their alveoli, which is responsible for gas exchange, is being destroyed, and there is some accumulation of mucus in those airways, making people prone to other lung injuries and other lung diseases. There are certain risk factors for lung cancer, and we do know there are some people that are at high risk. One thing that I always explain to people, that aging is a risk factor. The older you get, the more at risk you become for certain cancers. We know that with lung cancer, at least 40 to 60% have been diagnosed with lung cancer at age 50, and usually it's a little lower for age 65 and older. That's when it's even higher. So when you look at some of these risk factors, smoking and secondhand smoke, which is something that is modifiable, radon exposure, which is air odorless, you can't see it, you can't smell it. And there are kits that you can test your soil in your home for radon exposure. Asbestos is an occupational exposure. Asbestos is a material that was used many, many, many years ago, but has not been used once we realize asbestos is a carcinogen. And of course, family history is not something you can change. You cannot change your genetic makeup, your family. So family history is a non-modifiable risk factor. Now, when we look at the stats from the American Cancer Society, we have information that was collected through the years, and we look at lung and bronchus cancer. So that means 1 in 17 individuals will develop lung cancer. And this is for male population. This is the lifetime probability of developing cancer in the United States. And we look for women, there's 1 in 18. I had mentioned before, women are 25% more to develop lung cancer than men. We're thinking of lung physiology and perhaps some hormonal interactions. So women are getting lung cancer and bronchus cancer more than men are. And actually, when we talk to our patients, it's like, what is lung cancer screening? Like, really, what is that? The goal of a lung cancer screening is simply to detect lung cancer before, in the early stage, before there are any symptoms, and where we can, and the treatment is way more effective. We know that lung cancer screening is only available for people that are at high risk, whereas 70% of women do get a prescription once they turn 40 to get their mammograms. As of right now, we do not have a lung cancer screening that is automatic depending on what age you are. It is only available for people at high risk who meet certain eligibility criteria that we will talk about. This is what we consider high risk. Someone between the age of 50 and 80 who smoked or a former smoker, and you have a 20 or greater pack year history, and there are some changes where we'd like to see it at 15 years instead of the 20, and we realize that aging is a risk factor, and that is why you'll see that if you look previously, these criteria have changed. It started at 55 at one point, and we realized we need to catch people 5 years sooner. Then they wanted someone that had a 30 pack year history, and we realized that we need to go back a bit and make sure that we get that 20 year. So these are the individuals we consider to be high risk. And we talked about cancer being, lung cancer being the leading cause of cancer deaths in the United States. 83% of cases at age 65 are diagnosed. I had mentioned before, 50 at the age of 50, I believe it's around 40 to 60% of individuals are diagnosed, and as you get older, it's higher. So 83% of individuals that get diagnosed with lung cancer are age 65 or older. And one of the tests we will talk about is the LDCT. Once someone is within that high risk category, the best thing to do is to see someone that can refer you to an approved lung cancer screening center. Your insurance will only pay for lung cancer screening if you're at one of these, the American College of Radiology has a website that you can find out which areas have been approved for lung cancer screening. So it's not just any place that has a CAT scan machine that you should send your clients or your patients to. You want to make sure that insurance will cover it. So CMS will make sure that this is a lung cancer approved screening center, and commercial insurance also. When you're having conversations with your patients, it's something I like to consider patient-centered care, also shared decision-making. When someone gets first diagnosed with cancer, it is very difficult, it is very stressful. In addition to that, someone is also smoking. So now they're having to deal with two two things at once. So, shared decision making is a process in which a healthcare provider discusses options and works collaboratively with the patients toward preference based decisions. So, you want to discuss with them what goals are important to you, what barriers should we resolve. They may have financial barriers, they may have transportation barriers, and what interventions can we make. So, I just want everyone to be open minded that you're not just telling patients what to do. You have conversations with them to make sure that they're part of their plan. And I mentioned before being part of an interdisciplinary team where I work with the different clinicians for the patients receiving their cancer treatments. This is very important for a patient to feel that the care is centered to them and that they're involved in making decisions also. With the computed tomography, I tell my patients that it's a donut shaped device. It's quick, it's painless, it's less than 5 minutes in and out. And what the machine picks up on, it takes slices opposed to just one picture, one computed tomography, slices, and is able to detect. You see that red area is where a nodule, it could be cancerous or non-cancerous, where nodules are picked up. When it comes to nodules and staging, when I spoke before about 0 to 4, and 0 is where the growth is found in the airway or the windpipe, and that has a best early chance of treatment and getting rid of the cancer altogether. So from the CAT scan, what they will do, they will look at the size, and I have here, this is what I also share with my patients. We all know what the top of a pencil looks like. We let them know depending on the size of the nodule that is found. The doctor will determine if you need to come back within a year to see if that nodule size has changed, and depending on how big the nodules are. Now, if we look at things that we can visualize sizes. We have oat cereal, we have a penny, and of course we have a golf ball. So this breaks down the risk of malignancy. It tells you what some of the follow-ups will be. So this is where your patient is someone that is really going through a lot, and it's a lot to process at one time. So you want to make it as easy as possible. Not everyone has a medical background or even understand some of these terms. So give them a visual so they understand exactly what it is you're referring to and what was found. We have patients that may say, I'm afraid, I don't want to go through that machine. Can I have an x-ray instead? And what we tell them is that we know that a chest x-ray is not going to be beneficial, that the lung cancer screening, low dose radiation exposure, it is the safest, it's the most reliable. X-rays were used in the past, but they were not as sensitive as the LDCT, low dose CAT scan, because they don't always show the changes that happen. So it was not something we would count on to help save lives. So that's why shared decision making allow that patient to understand that yes, you may want an x-ray, but it's not going to be helpful if we're going to be able to treat you successfully. Unfortunately, we know that screening rates, there's a lot to be done with screening rates. We looked at the statistics and the data that was found that there are many Americans that are eligible, but they do not receive lung cancer screening. We have fewer than 6 in 100 overall in the United States that will receive it, and certain states is as low as 1 in 100. So when we talk about that, we know that there are certain health disparities. There are certain communities with certain disparities, certain ethnic groups that are more prone to lung cancer. However, they may not have access. We have rural individuals. When I discuss certain risk factors, we know that rural individuals may be drinking from well water, which is contaminated with arsenic, which somewhat would put them at higher risk for cancers and especially a lung cancer. So we need to do much better when it comes to getting individuals screened. We are falling far below the target goals of lung cancer screening in the United States. Pack years is how we figure out if that person is eligible for lung cancer screening. And pack years may take a little bit of math to see if you get to that 15 to 20 year pack year history. So literally one pack year, if you smoked one pack a day for 20 years, that's a 20 pack year history. If you smoke 2 packs a day for 20 years, that's a 40 pack year history. If you only smoke 2 packs a day, but you only did it for 10 years, that's a 20 pack year history. So even if someone quit for 5 years, they went back to smoking, we say take the most amount of time that they smoked and you add in those years to get to the pack years that will have those individuals eligible for lung cancer screening. We know that yearly screening is best for people that are healthy enough to have surgery and other treatments. That's why we looked at the nodule size. They may have you come back in 12 months to see if that nodule size has changed. And also, we know when people are, some of the risk factors that I mentioned is also sometimes it's unnecessary screenings are done and they're finding cancers that normally would not have affected individuals, and that increases their cost for treatment. So yearly screenings are done with the nodule size in mind, and it's a whole process that they go by. And of course, if you have other serious health conditions, your doctor may not recommend an annual lung cancer screening. So lung cancer screening, I had mentioned before, is not currently available for people who had smoked occasionally, smoked marijuana or vaped. However, as a clinician, I had, when I worked for a previous organization, when I was working mainly with COPD, emphysema, asthma, lung diseases, we had an individual, he was 38 years old, he had been smoking since he was 12. He technically, because of his age, is not eligible for the low dose CT scan, but his doctor ordered a diagnostic lung cancer, lung CT, and they did find a nodule that was precancerous. So just think about the age of your patient, the eligibility criteria. Yes, they may not fall, they may be 40 and have that large pack year history. So that primary care physician may say, I still want to do a lung CT, and they would find a nodule. So just make sure that even though someone is not eligible based on the criteria, they still may be able to get a diagnostic lung CT, and it may pick up a lung cancer. These are some of the risks I did talk about. It can be very helpful, but yes, it does have some risk. It may not find every cancer, or it may suggest you have cancer when you really don't. We talk about LDCT because it's a low dose, but when you keep getting CAT scans over and over again, you're risking yourself to be exposed to higher and higher radiations, and you could be exposed to developing a cancer with high doses of radiation. And they may find another health condition, I alluded that to before, and additional tests may need to be done, and of course that adds cost to someone's finances. So just know that we know how helpful it is, but we are also aware that there are risks associated with these CAT scans. I mentioned that our lung cancer screening rates are very low, and it has to do with the healthcare systems, different populations in the United States that do not have access to healthcare, and there may be some systemic biases with certain groups. We know that 40% of adults who smoke do not often receive advice to quit from other healthcare professionals. When I have given education to radiology groups, oncology groups, they will tell me that when they are treating a patient and they ask, "Do you smoke?" they will refer them to their primary care physician, not knowing that their primary care physician did not even ask if they smoked. So provider utilization, please be aware if you are working with clients, don't always think all their doctors are referring them to quit. Fewer than 1 in 3 adults who smoke use cessation counseling or FDA-approved medication. So that's fewer than 1 in 3. Most individuals that will say, "Oh, I quit cold turkey," I congratulate them, but only 4 to 7% of the population can quit cold turkey, and relapse is extremely high. So fewer than 1 in 10 adults in the United States have been successful with quitting each year. We tell everyone that it may take you 8 to 10 times before you can quit successfully. So just know that your primary care physician may not always ask. There may not be anything documented in an EMR, electronic medical records. So what I would like to see as a clinician is that with your vitals, in addition to getting your weight, your oxygen, heart rate, and blood pressure on every visit, we should be also documenting smoking status. I may have checked someone in September, "By the way, are you a smoker?" And they say no, and they never ask them again. Patients do not always tell the truth because they're embarrassed and they don't want to tackle their tobacco use. So please make sure that that it's documented at every visit with your clients and your patients. Before someone even has had one cancer treatment, we do know that by not smoking, you have increased your risk of survival. Okay, by not smoking, by just stopping alone, you increase your risk of surviving. When someone continues to smoke, it's only a 33% survival rate at 5 years. When someone stops smoking before any treatment, their survival rate goes up to 70%. So we know that we can no longer ignore person's smoking status because it's proven scientifically that we need to understand tobacco use and to make sure people get treatment. And it's no longer ethically acceptable to ignore someone's tobacco use. Smoking cessation and cancer, this is to help prolong lives and help someone to go throughout their cancer treatments tobacco-free. When we have lung cancer screening, it's a great opportunity to get people into tobacco cessation. So if you have someone with a suspected lung cancer and they're going for screening, this is a great time to talk about smoking treatments that are available. 5-year survival rate, I did discuss this in previous slides. This is just to show you can get these statistics for your state specifically to see what the 5-year survival rates are. June is National Cancer Survivor Month. I'm big on advocacy to get the word out. So again, if someone is diagnosed with lung cancer, I want them to know there's still a lot of life ahead, and the treatments and everything that we do is to prolong their lives so they not only survive, but they can also thrive. If anyone in the state of New Jersey can please do me a favor, I'm on a coalition for cancer survivorship with the State Department of New Jersey. And what we have created was a survey for everyone in the state of New Jersey so we can understand what cancer survivors need to live their best and healthier lives. If you take a screenshot of this, provide this to your clients, this is a great way for survivorship information to get throughout the state of New Jersey. Quick interventions. You yourself may not be able to help anyone with tobacco cessation, but you want to make sure your clients are getting the help that they need. Ask if they smoke. It takes less than 1 minute. And if they do, explain to them what you understand about tobacco use and their health and cancer risk, and advise them. just make a quit plan. We always say you have to make that decision when you're ready, set your goals, get a quit date, and you have a tobacco treatment specialist that will help you have a quit plan. And you see it's not just regular tobacco, but it's also vaping. Everyone, we all know that our Department of Health for the country, which is FDA, CDC, has not been open. So if you go to their website, it'll say, due to the government shutdown, we are closed, and some of the information on these websites may not be up to date or accurate. Just make sure that you're aware for your individual state. Look at local municipalities of what is available, because right now we have a government shutdown and there have been many cuts made, and the Office of Smoking and Health has been eliminated by the CDC. There's a reduction in the workforce that takes care of surveillance. I mentioned all these numbers and statistics that we receive is collected from our federal government. So you want to ensure that your information is up to date and accurate. Please look to your state and local municipalities for information. This is a 800 number for the entire United States. This is a quit line that is free, and you will get a tobacco treatment specialist. It doesn't matter where you are in the country, in a state with the different counties, it'll route you to your nearest quit center. I'm big on advocacy. Some people need a particular goal to have a set quit plan. We know in November, the third Thursday in November is the Great American Smokeout. There's No World Tobacco Day on May 31st, and there's many, many more. I just wanted to show you some other moments of advocacy to bring about tobacco cessation. Key takeaways: if we do not help people quit smoking, we will not adequately reap the benefits of lung cancer screenings. Early detection of lung cancer improves diagnosis, and we still do not know the long-term effects of vaping. We still don't know. And those are our key takeaways. This is my information. This could be provided in the chat. If anyone would like to speak with me, reach out to me, get information. And thank
Thank
you
you,
for
Monica.
listening.
That was so informational. And I'm going to post all of the information into the Mighty Networks, including the survey link and all the links that you posted. So make sure you check out our Mighty Networks for all of that information. I'm going to stop sharing and switch my screen over to Frankie's slides, and then we'll start there.
Monica, fantastic job. Lots of terrific information. I was excited to see the questions in the topic. I mean, in the chat. I also love that we're going to have some overlap in a lot of what we're saying and sharing. So sometimes, I love the old mnemonic of if you hear it 2 and 3 times, it's going to stick. And there's the teacher in me. So I work as a tobacco treatment specialist, and what that means is I help them quit smoking. A lot of patients are told, you should quit. You need to quit. No one tells them how. I help them figure out how. So as you can see, my name is Carol Francis Spear. Everybody calls me Frankie. If you want to send me an email, it will be to carol.spear@rwjvh. I do work with the Institute for Prevention and Recovery under the auspices of Robert Wood Johnson Barnabas Health. So we're going to talk about how I work with patients who have lung cancer diagnoses. And this is a little bit about our program. And typically, though we are focusing on lung cancer in this presentation, this is really my approach with any patient that I work with. I want to know what's happening with them, because what's happening in their physical health absolutely impacts their mental health. And since we can all pretty much agree, stress is a huge trigger for people to smoke. So it's important for me to understand all the things that are happening. So we have an 8-week program, and that 8 weeks entail a patient would be referred to me, and I'm going to touch on where the referral sources come from a little bit later. A patient will be referred to me. I will do an assessment. Our assessments are extremely thorough. There's 4 different sections, and it takes typically about 40 minutes, give or take, to do this assessment. We cover everything from the demographics to their health history to their smoke history. Once the assessment is complete, if it's appropriate and the patient is interested, we would provide them with a month's worth of free nicotine replacement therapies, like the gum, the patch, or the lozenge. We do it in 2 orders. This really allows the patients to really try and figure out what works for them, because it's not a one-size-fits-all. My goal, and I tell this to my patients, I'm here to set you up for success. I'm not here to judge you. You got friends and family for that. That's not what I'm here for. If you're more comfortable when you quit, you're more likely to stay quit. So I do a lot of cognitive restructuring. I do a lot of just reframing and just looking at things from a lot of different perspectives and just retraining the brain. So once they've been assessed, I'm sending them products, then we schedule weekly visits. For 7 weeks, I'll do check-ins with them, and we'll schedule the time so they can do it from the comfort of their home, which really makes it a lot more accessible for people. I have a lot of patients who are not ambulatory, or who, may be living in, an assisted living facility. It wouldn't be possible for them to participate in the program if they had to drive out to see me. I do have patients that will meet me in the hospital, and that's terrific when that can happen. So I try to be available in either capacity, but the bulk of my patients are hybrid, and we're doing things on the phone. So again, we have the assessment, 7 weeks. Okay. And all of our data that we collect is used by the Rutgers Tobacco Studies Program. And I really make a point of telling patients right up front, thanking them and saying that by doing this, you're helping anyone who has ever smoked, because we use this data to train people like me, to train providers, to inform policy, to understand trends. And I've noticed since I've been incorporating that big thank you right up front, I'll get them to be a lot more attentive when I'm doing a survey. They're like, okay, I matter. Yes, you matter. What's happening with you matters. And that's a big piece. I did see a question in the chat about mental health issues with smoking. Absolutely. Huge overlap. So can we go to the next slide? Okay, so some of this information is going to look familiar. All right. So this is just kind of an overview of that tobacco is a preventable cause of death. Nobody's born smoking. Nobody said, oh, I want to start smoking and just keep on keeping on. No, I have a patient who is 84 years old. She started smoking when she was 7, taking cigarettes out of her father's truck. She even used to pick tobacco in fields in Florida when she was a little girl. She said, oh, I tried cotton, and then I realized you have to pick a lot of cotton to make a pound. So she started picking tobacco. She also has had a recent diagnosis of lung cancer. She will not be the case I'm going to discuss today, but she's still trying to quit. She still keeps that hope. And that's so critical, because there's so much guilt. There's so much shame, especially when you get a diagnosis of any type of cancer, but particularly lung cancer, because it's so easy to make that connection. I know doing this did this. And you feel guilty. I hear constantly, I was so stupid. I was so dumb. Why did I do this? Why did I do that? This is when my background in special ed comes in extremely handy, because I reframe it. It's like I remind people, you didn't start smoking. Tobacco was created to addict and hook you. The tobacco industry hates people. And you'll hear me say it once, you'll hear me say it 1,000 times. They hate people. What pays for this treatment is because the tobacco industries were so nefarious. My program is grant funded. Well, all those years ago, when tobacco companies were sued for not being so forthcoming with how addictive their product is, that money was set aside to be used for treatment and prevention. That money allows me to work with patients. So my job is grant funded. Our services are free, which is also a big selling point. It's free. You have nothing to lose. Let's try. And Monica's right. The statistics of people quitting multiple times, Data shows it does take multiple times. When someone quits on the first try, I'm like, fantastic. The world needs more unicorns. That's terrific. But for some people, it's harder. When patients say, oh, I've quit before, what's going to be different? I give them the data point. You know what? You have quit twice before. Data shows it takes more than 2 times. This could be your golden time. Hooks them in. It's a lot of positive language because this is serious. The number of deaths, that's almost 500,000 people. And this is a stat from a 2014 report. Okay. The data is much higher now. Can we have the next slide, please? This data is a little more current. This is from the National Cancer Institute, and this is very similar to the data that Monica was showing you about the estimated new cases of lung cancer, the estimated amount of deaths, the survival rate. That's terrifying. No one thought when they started smoking, I'm going to die. This is going to kill me. You're like, yeah, someone else. And it's so, so difficult. I've lost 3 people in my family due to smoking, the most recent one in July. She died from respiratory and pulmonary failure, followed by cardiac arrest. Didn't tell anyone she had COPD. I work in the field. She said nothing. She said nothing. And that is how she passed. My uncle, on a heart transplant list, told if you don't quit smoking, we're taking you off the list. The addiction was so hard, he couldn't quit smoking. Now, it's one thing to live without a kidney or live without a toe. You need a heart. You absolutely need a heart. And the addiction was so strong, he couldn't stop smoking. So it's very serious, and we have to be very mindful and respectful of this. A lot of people may make jokes, or again, you're told just quit. Why didn't I think of that? But this program makes a big difference. There's something about having that accountability. There's something about having the opportunity to really discuss what got you smoking, what you use smoking for, how does it impact you, and what can we replace how you use it for? Can we go to the next slide, please? So as you can see, this is again very similar to the data we saw before about the incidence of cancer and the resulting, like the top ones there. If we can go to the next slide. So my referrals come from all different sources. And I do have a slide at the end. If you'd like to make referrals to us, I will tell you how. But they come from all different medical providers. And when I say all different, I mean orthopedic. Guess what? If you have to have an orthopedic surgery, your surgery is getting canceled if you're a smoker. That'll make someone come. Why? Because data shows nicotine does not allow your body to heal properly. I have a current patient who just had a double mastectomy. She's a week and a half out, and she quit smoking before her surgery. She noted that her recovery feels totally different than when she had her pancreas removed because she was still smoking then. And she goes, I don't know if it was the nature of the surgery. She goes, but I don't feel as sick. She goes, do you think it's because I'm not smoking? Yes, I do. Yes, I do. Good insight. Yes, it makes a difference. So all different departments refer. I might have a patient who's referred by an orthopedic, but guess what? They might also have cancer. So even though a referral comes from, a urologist or maybe it'll come from a pulmonologist, that doesn't mean that the referral may not have cancer. There's often a lot of comorbidities, often. So we get referrals through Epic, through medical. If you are in the emergency department and if they ask you some questions about smoking, Monica's right, always asking. You have to ask at each point, because at one point there will come the time when the person goes, you know what? You keep asking me this. All right, let me give it a try. All right. If you go to the ED and you test positive for tobacco on a tap screen, you'll get referred to me. You can call a quit line. 2 different numbers here, right? You can also go to the website. I also work with inmates. I have inmates that are incarcerated in halfway houses that do treatment over the phone. I can send them 2 NRTs. They can use patches and they can use lozenges. I can't send any gum, can't send any medication, but we work it out. We adjust and work in that genre. Social service agencies, a lot of those community outreach events. Those are fantastic to meet people and to let them see who and what you are. And always keeping in mind, cultural connectivity, key in service delivery. You have to meet people where they're at. You have to understand where people are. Next slide, please. So here's the stats on our program. Since 2020 on Epic, we've had 616 oncology referrals. Okay. Keep in mind, all RWJ providers were not enrolled into Epic until April of 2022. So since April of 2022, 364 oncology referrals. This is just in New Jersey. Okay. This is only New Jersey. Now, a lot of these people they're not unique. They're repeatedly referred. That highlights the importance of having that conversation every time. I have patients that I've perhaps made 5 different contact attempts over the years from different referrals, and then boom, one day they pick up and they're there. It has to be when the person is ready, and that's so important. Again, it's just respecting. Yes, we'd like you all to quit. We'd like nobody to smoke, but there's an expression I used to use when I worked with brain injury patients. You can lead a horse to water, but you're not allowed to drown it, but you can splash it. I'm all about the splashing. Let me just splash you. All right. Again, as I said, patients diagnosed with cancer may be referred by an alternate provider. Just because it's pulmonology doesn't mean it may not be a cancer patient. So at the bottom of this slide, I have information about our landing page and how to call and the numbers to call. And again, I'm happy to provide this information to anyone with time of the essence. I'm not going to type it in the chat now, but I can get information to you. Fear not. Next slide, please. So once I get a referral, here's my process. I look at the snapshot, whether you have cancer or anything else. I look at the snapshot, not to be a nosy looky-loo. I look so I can get an overview of what's happening with this patient. Is this patient in and out of the hospital quite a bit? Do they have multiple comorbidities? And how is that going to impact how I treat them? All right. And not in terms of my tone, but in terms of what types of treatments I can offer them. That's what I'm referring to when I say what type of treatment I can provide. I'll typically make 2 contact attempts, but I'll check the encounter. If I see a lot of medical comorbidities and I made a call, I'm on my second call and maybe I haven't heard back, I'll check the encounters. Maybe they were at an appointment. Maybe they've had several appointments. Maybe they're hospitalized, and I'll do a 3rd attempt. All right. Next slide, please. So once I have someone saying, yes, let's do an assessment, I'm like, rock on. I give my thank you so much. You're a wonderful citizen for doing this. This is an extremely brief overview of the assessment. As I said, 40 minutes, give or take. And if they have multiple comorbidities, oh, honey, I could be on the phone for an hour. If they are tangential, if there's often a challenge with yes and no questions. If I ask you if you've been pregnant, that's a yes or no question. I'm often given a story of every single pregnancy. So you really have to try to, keep people focused. You want to listen. You don't want to invalidate, but you really have to do your best to kind of guide the conversation with the patient. You don't talk at them, talk with them. So I'll get your demographics. I'll ask you, we'll set a quit date. That's the first seed. It's the first thing I ask. Can you commit to the 8 weeks? All right, let's set a quit date. Often, oh, what if I can't quit by that date? That's okay. You still got me for 7 weeks anyway. If you quit before then, fantastic. If you don't quit by then, fantastic. I just want you to start thinking about it, because sometimes just having that date, and often they'll write it down. Writing is a mnemonic. That's how it starts. That's how it starts. Okay, I'll ask them about their education level, all that other stuff, just to get an idea. I'll ask them about their nicotine and tobacco use history. How old were you when you started smoking? Can you go back to the previous slide for a moment? What their motivation is for quitting. And that's important, because I'm going to use that. If they say, my uncle Paul passed from lung cancer, he was my favorite uncle, I'm going to weave Paul into conversations. I'm going to help use it. Maybe keep a picture of Paul, and you drive a truck for a living, put a picture of Paul on your dashboard there, so you see Paul, because you smoke when you drive. If you see Paul when you're in the truck, maybe you won't smoke as much. Little subtle things. That's not a strategy they teach you in tobacco school, but it's really listening to find what motivates that person. You see here, there's the Fagerstrom nicotine dependence assessment. That's part of our overall assessment. And this just gives you an idea of the degree of addiction. Because some people, maybe they smoke one cigarette a day, but they relight it 4 times. A little more of a nicotine addiction than the person who smokes just one cigarette. You have to have an idea of what their addiction is, how quick after they wake up, how soon. My vapors often sleep with a vape under their pillow. And I have assured them the vape fairy is not visiting to bring them a new lung. That is not safe. And it's a lithium battery, and your pillow could catch on fire. So maybe don't do that. Just educating people all along the way. Next slide, please. So again, we take their medical history, and this is sometimes where it takes the longest if there are a lot of issues. Monica showed before, many of the top conditions that we find with smoking. Those are the ones I ask about them first. Have you ever had any heart disease, high cholesterol, hypertension, diabetes, lung disease? And you'd be surprised. Again, our data is what the patient discloses. Some patients don't identify that they have some of these diseases, either because they don't know, or there's a literacy factor, or they're embarrassed. I've definitely had patients with COPD not tell me they have COPD. And I can hear, everything okay? Yeah. But they don't want to tell me, but I see in their chart that they do. So I'll try to tease it out by going over what medications do you take? Do you take blah, blah, blah? Oh, I see you have this. Oh, now a butyral inhaler. Do you have asthma? Oh, I have COPD. Okay, well, thank you for sharing that. Sometimes you have to tease it out while still respecting their boundary, right? But I need to know these things so I can give them the right NRT. Because if you have kidney disease, guess what? I can't send you Chantix. That's not good. That's a problem. If you have a history of profound mental illness, bupropion may not be appropriate for you. So it's important to try to get as accurate a picture as you can while still respecting their boundaries. Next slide, and water sip. Okay, patient-centered care. We've heard that a lot today. That is critical, and that's what you want for anyone. I want it for my family. I want it for me. I want it for anyone else. No one needs to be talked at. You have to meet people where they are. Cancer is a terrifying diagnosis. You just hear the C word and your brain connects to death immediately. I don't know one person, and I would love to meet one when they heard cancer, didn't immediately think I'm going to die. And that's really heavy. That's traumatic. And so there's a lot of different levels. You have to be patient. You have to give people the grace to express themselves. I know on days when some of my cancer patients have appointments, I need to book a few extra minutes in that session because they're having a hard time. They need to talk about it. And while I'm not the cancer counselor, I am a tobacco counselor, and your state of mind impacts your smoking and your ability to quit. So I do need to take that into consideration. When appropriate, I absolutely, do you have a therapist? Are you speaking with someone? Can I link you to a support service? I do offer those things, keeping in mind symptoms of inflammation mimic symptoms of depression. And cancer treatment, your body is inflamed in a lot of areas. So you're going to be depressed. That's normal. That's okay. Normalizing what they're experiencing, letting them vent, maintaining awareness of support resources. Oh, there's a support group, over here. Oh, there's a cancer closet here where you can get some supplies, if you need, or do you need a walker? Do you need a chair to go over, your toilet? Do you need nutrition? Like just maintaining awareness of support resources to share with them because they might not know. Do you have someone to go to an appointment with you to write down stuff? Keeping in mind their physical symptoms, always encouraging them to speak to your doctor, follow everything that they're saying, and trying to keep it in mind when creating strategies. Like if you're having a treatment session on a Tuesday, I know you're going to be more tired on Wednesday. So I'm not going to schedule a session on a Wednesday. Let's do it a different day. Being flexible. Maybe you thought, oh, in a few days I'd feel better, but you don't. That's okay. I'm not going to cancel that session. We'll add another session on. That's fine. Being able to communicate, being willing to reschedule, which is hard given the abundance of referrals we get. It can be really challenging, but letting patients know you're important enough to me that I want to make sure that I have space for you on the calendar. just letting them know they're still important. Dealing with the guilt of I'm still smoking and I'm doing chemo. And I have a lot of patients that smoke while they do chemo, and trying to educate them on like, oh, it's kind of counterproductive, and empowering them with knowledge. I always tell them, as I told my students, you might not always like what I say, but I will always tell you the truth. Um, if they're doing radiation, they may have very dry skin. Guess what? That patch might not be the best NRT to use at that time. So maybe, adjusting the use of the patch, using alternate NRTs, encouraging them to use moisturizers. Next slide, please. Financial stress. You might not be working. You might be completely, distraught, despair. You may not have qualified for your disability yet. You could be in limbo. So keeping myself aware of any free or low cost resources around you, like charity care. I have a patient who needed a lung cancer screening who had no insurance. At an outreach event, I was seated next to the lung cancer screening guy. And he said to me, he's like, tell your patient to apply for charity care. If he meets the criteria, he can get a lung cancer screening. Well, how useful was that for me to be able to give back to this guy who was paranoid because his father died from lung cancer and his brother, and he smokes like a chimney, but he had no insurance. So I was like, here, like keeping an earful of this. The cancer prevention pantry, fantastic. I've had more patients grab things from there, and this picture is an actual picture of the produce that was in one of the bags. That's incredible. That's a lot of produce, And as she was saying, she goes, I don't know what two of the items are, and two of them I don't like, but I gave them to my neighbor. She has an elderly neighbor who, doesn't always go out to the store, can't afford to. So it paid forward twice. That was fantastic. It costs nothing to know that. It costs nothing to say that, but just keeping those resources in mind, trying to help where you can. And not everyone's brain can be a Rolodex, but when you hear a resource, try to archive it, try to write it down, make a spreadsheet, however you remember things, keep those resources because they're handy. You never know when it's going to come in handy. Multiple patients of mine have gone to that Kinney Community Gardens in Newark, multiple, and it's been a blessing every time. Next slide, please. So here's my case study, trying to wrap it up, and I appreciate you all staying on a little late here. So my case study, I have a 71-year-old Puerto Rican female. Monica, I am sorry, I did not find out if she had the non-small cell or I'm like, oh, learning every day. Every day is a great day to learn. So now I'm going to have to jump back in her chart and be like, so what kind does she have? So of course she had to quit smoking before they were going to get on in there. They wanted her to quit or at least cut down. She had had a bladder cancer diagnosis that was treated and resolved, and then developed, and that was at 62. She developed stage 3 lung cancer at 67. She was a pack-a-day smoker. Started smoking at 9. A lot of these seniors, they were rough kids, boy. They're all smoking like before 10 and 11 years old. Times are tough in the elementary schoolyard. She had 2 quit attempts. She went a year, which was fantastic. Then 3 months. A lot of trauma and stress she's had in the time I've worked with her. She had 2 deaths in the family, which was really frustrating for her. She lives alone. As you can see, multiple comorbidities. Was a boredom smoker, of course. Stress. And she lived across the street from the hospital. So we were trying to figure out, and she's in recovery too. And I love when someone has recovery from substances or opiates. I always tell them, like, that's such a strength. That's going to serve you because you already know how hard it is to quit something, and you've done it, and you saw the world didn't come to an end. You can do it. So it's a strength that's going to serve them. So we were trying to find things to keep her busy, keep her hands busy. She told me, oh, I used to like to do crafts, blah, blah, blah. So I was like, well, what kind of crafts did you like to do? Because again, muscle memory, it's not just the nicotine addiction. It's the rituals we associate with it. It's what we're doing. Oh, when I drink coffee, I smoke a cigarette. When I drive, I smoke. Half the time, people don't even realize when they're smoking. Next slide. So if you see that lovely pot holder down there in the bottom, so my patient was scheduled for a wedge resection, and she was going to have chemo after. So again, had to be nicotine free. We used the NRTs. We used bupropion. We used the patch and lozenges. She had full dentures, so she did not want the gum. So always ask, hey, do you have dentures? Are they top and bottom? And explain the gum isn't chewed like regular gum, but still it does stick to dental work. We met once a week, for psychoeducation, behavioral substitution, cognitive restructuring. And what she came up with, she started making pot holders. That is her hand, and that is her pot holder. I She was so excited. You can see I don't know if you can tell in the picture, she's got a walker. When she came to my office that day with that plastic bag, I'm like, oh my goodness, I know what's going to be in here. And she was so excited to show it to me. She was so excited to do it. She uses that. She uses coloring books. She does any number of things. She got her tobacco down. She had her surgery. She's got a lot of pot holders. See me after this presentation. I'll be selling them out of my trunk in the parking lot. If you need pot holders, we've got them. Next slide. Okay, so it's just thinking outside the box. A lot of what I just said, read the room. You have to meet patients where they're at. You don't need to judge or get frustrated with them. They do it on their own. As I said, I don't need to judge you. You got friends and family for that. That's not what I do, which they always giggle at when I say it, but it's the truth. I'm here to celebrate them and be their cheerleader. I use this thing all the time. When my patients hear that, they know that they've done like something awesome. And when they don't hear it, they're like, Frankie, where's the bowl? Where's the bowl? And I'm like, oh, I said I haven't smoked in 3 days. Oh, that's terrific. It's just a reinforcer. That's from my old teaching days. It's just a reinforcer. Make them feel a part of it. I always tell them, I'm not going to tell you what to do. I'm going to guide you, and we're going to do this journey together because everyone's journey is unique. Yeah, there's some commonalities, but everyone's journey is unique because you're the only you there is. Listen to what's important to the patient. I might want you to quit smoking because I know you need to quit smoking, but I have to listen as your patient's like, I use because my sister just died, and this is how I feel close to my sister when I smoke. I got to come up with a clever way to help you associate something else with your sister. So instead of going, stop, 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 that's silly, I have to listen to that and honor that. And I have heard that from patients. Empower them with knowledge. Knowledge is power. I'll send a picture of a European cigarette pack, which if you haven't had the pleasure of seeing one, treat yourself. They are delightful. Understanding their abilities and interests. If I have a patient who's not ambulatory, I'm not going to say, hey, go take a walk when you feel like smoking. That's probably not a good suggestion for the person. So understanding, what they can and are interested in doing. Encouraging them, using combination therapies. There's a lot of misunderstanding about how the patch works. I don't know where these conversations happen. I'm a tobacco treatment specialist. I've never walked up on a casual conversation about patches, but I'd say 40% of my patients say, I heard this, I heard that. So giving them, accurate information and explain how to use the combination therapies, encouraging them to communicate to all of their providers. Like, never assume that your doctor's going to have time to look through your chart. Let them know, I'm participating in a tobacco cessation program. These are the products I'm using. I'm hoping to be smoke-free, blah, blah, blah. Another thing I do, which is, again, they don't teach you this in tobacco school, because I worked as a special ed teacher, because I worked with brain injury patients, because I'm just ridiculously overly human sometimes, when I have patients that have an upcoming surgery or even a job interview or something that they're very stressed about, I'll send a little motivational message. It takes me 10 seconds. Hey, thinking of you today, sending you lots of, positive energy or good luck on the interview, just a little thing like that. Now, if we switch to the next page, I will also send you this. Now, I can see Sarah smiling. I can see Evelyn smiling. Now, I will tell you why. Oh, and there's Monica smiling too. I will tell you why I exploit my puppy as a therapy dog. Studies show when you see a puppy, guess what just got released in your brain? Oxytocin and dopamine. Dopamine is also what's released when you smoke cigarettes. That's that feel good, like, I feel so much more relaxed despite my heart rate being up and my blood pressure, So I'll send something like that because Laughter is the best medicine. Positive energy can be good medicine. So you'll get a cute little picture of my dog and see, and you got to see and experience that is how it worked. Oh my goodness, everyone went, ah. All right, next slide. So again, once again, here are the ways to enroll in our program. So take down that info. Also, if you are a provider, we have a tobacco liaison, Cynthia Kinsella, and once everyone has copied the info off of that slide, we'll go to the next one so you can see. She can come into your office and teach you how to do ask, advise, refer. It's a very specific process. And if you're interested, please put your name in the chat. I will have her reach out to you. If you can go to the next slide. Oh, one more. Whoops. I'm a little verbose, I see. And one more. There we go. So you'll see Cynthia's down on the bottom there. She's our tobacco liaison. My contact information is up near the top. You can see I'm going by my government birth name of Carol. But if you call me Carol or Frankie, I will still respond to you. And if I call you from my hospital phone, it will identify me as Kelly. So whatever you choose to call me, as long as I can help you, whether it's help a patient, help you to help a patient, or help a patient to quit smoking, it doesn't matter to me what you call me, as long as we all help each other. And so I thank you again. I know this was a very brief overview. I hope it was useful for you. And yeah, thank you so much for your time and attention. I don't know if we have time for questions or anything, but that's my elevator pitch. There you go.
Thank
That was
you.
great. Thank you for sharing. I'm gonna pass it to Evelyn. She'll be doing the questions and send the rest of the links in the chat. I have to hop off, but that was a great like echo session. I really enjoyed both of your presentations. Thank you.
Thank you, Sarah.
Thank you, everyone. I'm just gonna throw up the poll very quickly. Um, let's let me just, interesting. Hold on one second, bear with me. I just need to move around my screens. Um, okay, I'm just having a little technical issue here of sharing that. Hold on. So what I'm going to do is we're going old school. I'm not going to be fancy. I'm going to just share the slide and then launch it. Sorry, guys. Zoom is acting a little weird. And then let me go ahead and launch the poll. And thank you again for staying. I really appreciate that. We really do. So the first question, you don't have to smoke to get lung cancer, true or false? Lung cancer is one of the deadliest cancers, true or false? Air pollution is a non-modifiable risk factor, true or false? Initial stages of lung cancer are usually asymptomatic, true or false? So if I can just get a few more of you to answer, we'll have Monica share, and I'm going to go ahead and end the poll. Thank you. And Monica, if you want to share the answers.
Yes, all the answers were actually true. Lung cancer, where are the questions? I'm sorry. Oh, here they are. Okay. So you don't have to smoke to get lung cancer. That is true. We know 7,300 individuals die from lung cancer every year from secondhand smoke. Lung cancer is one of the deadliest cancers. We have shown you statistics and facts worldwide also. Air pollution is non-modifiable. You can't change it. And if you're exposed to air pollutants, yes, so that answer is true. Initial stages of lung cancer are usually asymptomatic, where you have no symptoms at all, and that is true.
Oh, sorry. Oh, fantastic. Thank you so much, Monica. And let me share the results. I think we have pretty good. The air pollution one, I could see where it can be a little confusing for people, but that is definitely non-modifiable. And I'm going to stop sharing. And then we did have two questions. One was from Melissa, which I thought was a great question on, is there screening guidelines for non-smokers or secondhand smokers?
There are no guidelines, but what I would say, if you have a primary care physician and you have symptoms or you're concerned about something, they can order a CAT scan of the chest to see if there's anything there. So there's ways around it. And your insurance may pay for it because it's not considered a screening. It could be diagnostic because of X, Y, and Z that someone is experiencing.
And then our last question, what efforts or deliverables have been more effective to educate the community in lung cancer regarding modifiable risk factors prevention?
When we do these educational outreach tabling, we'll talk about diet, we talk about things that, secondhand smoke exposure. We do the outreach and educate the community. And once they are empowered with the information, we hope that they do make those lifestyle choices, those changes for better health.
Wonderful, thank you. So I've just dropped our Mighty Networks into the link. If you are, please use that to check in and get the resources, the recording for the presentation, and then more importantly, so that we know how well we're doing and we can bring more programming like this to you. I also just dropped our evaluation link, and we'll also send that in the session guide as well. I know we're at 11:29. Thank you so much, everyone, for staying. I don't know if anybody has another question they want to unmute and ask real quickly, or if we're all good, we can close out. But thank you, Monica. Thank you, Frankie. These presentations were excellent, giving us insight into the treatment, the details with the lung cancer screening. Thank you so much. And thank you, everyone, for joining us. Our next session, we're launching our gynecological cancers presentation. And that will be on the second Wednesday of November, on November 12th at 10 a.m. Eastern Time. Thank you and have a great day.
Thank you,
Thank you.
everyone. Thanks, Frankie.
Thank you, Miss Monica.